How
Sir,
much time for me?
yeah, it's okay. So somewhere between 45 minutes to 1 hour should be fine.
Okay.
Yeah.
I would rather take 45.
All right. So let's start. So good evening and welcome to this international webinar at Believers Church Medical College and Hospital. Today we have a very, very intriguing topic, artificial intelligence in healthcare. Well, this is going to be the future of healthcare, arguably though, of course, with clinical expertise going hand in hand. But then artificial intelligence, robotics, and deep machine learning, everything is right in front of us and it's here to stay. So we need to home in on this, we need to learn more, and we need to really learn the ropes. So today we have with us our distinguished speaker for the day, Dr. Uli K. Chetipalli. So sir is an emergency physician by training, ardent researcher, author, and a path-breaking innovator. He is currently the president of Innovator MD, a healthcare innovation company. As a physician scientist, he is interested in technology-enabled care. He received the Pioneer Award for Innovation from Kaiser Permanente and Morris F. Colon Research Award from the Permanent Medical Group. His other roles include President of the San Mateo County Medical Association, Chairman, Society of Physical Entrepreneurs, San Francisco Bay Area chapter, advisor, mentor, and investor at various healthcare startups. His book, Punish the Machine, The Promise of Artificial Intelligence, one which I've added to my bucket list in healthcare, is available on Amazon. So, sir, it's a great privilege to have you as the guest speaker, international guest speaker in our platform. It's a great, great honor. Welcome, Dr. Uli Chetipalli, sir. And on the panels, we have two distinguished personalities. Dr. Arvind Singh, sir just did an amazing webinar with us last week. So it's a great privilege, sir, to have you back again as panelist, as the international panelist. Sir has trained from CMC Vellore, and he went on to train in oncology, and apart from various other entrepreneurial startups, there it is behind him, Triquetra Technology in clinical medicine. Over to you, sir.
In India, in Hyderabad, Osmania University. And I do have a lot of friends at, CMC Vellore, where, I have friends and relatives who have worked there and graduated from there. So it's a pleasure. One of the things that when I first came to the US, probably what brought me to the US was, this desire to learn. So when I came here, I first joined UCLA, University of California, Los Angeles. Did my master's in public health. That's what MPH stands for. The idea is to learn on how to take care of populations. In medicine, we learn about taking care of individual patients, right? When we think about epidemiology and population health, how do we take care of large populations? So that is my background. That's how I got into healthcare, and also how I got into public health and population health. One of the roles that I play, I started my own company a couple of years ago. It's called Innovator MD. I'll tell you a little bit about that in a bit. I also started a Society of Physician Entrepreneurs in San Francisco about 6-7 years ago. Until recently, I was running it, and now the next leadership has taken over. San Mateo County is it's like counties are like districts. We have a medical association of about 1,000 plus physicians, and I am the president of that association. It's a body of organized medicine. My last job, where I did most of my work, was at Kaiser Permanente. Kaiser Permanente is a large healthcare company. It is an insurance company, it's a hospital company, and also a medical group, what we call an integrated network. And within that company, take care of about 11 million patients, within its hospitals and medical group. I started a group inside of Kaiser Permanente called CREST Network. The idea is to have emergency physicians who are interested in research join hands and help with doing research at a digital level, not necessarily directly interacting with patients, although that is part of recruiting efforts. But how do you use data to be able to do research? I was the technology lead for the group. So that's a little bit about my background. Now, what I'm going to talk about is from my experience as an emergency physician and as a public health physician in the United States. Where I'm located is in California. I'm in the San Francisco Bay Area, what most of us call Silicon Valley. So I'm right in the middle of all the innovation that is happening in the technology field, in the biotech field, and where that combination of technology and biotech come together in one place. So when I talk about things, I'm mostly referring to the US healthcare system. But also there are many things that are applicable to the rest of the world, and many things that are applicable to India and Europe and other places. Now, although the healthcare systems may be different, the business model of healthcare may be different in each of these countries, what is common is one thing. The two basic players in a healthcare system, obviously, are the patient and the physician. So those two are common for a healthcare system anywhere in the world. And that's where I tend to focus on, the interaction between the patient and the physician, the knowledge that the physician has, and how that knowledge is used for the patient's betterment. How does it affect patient outcomes? That is the core of my research, and the core of my my thesis is that is where the biggest difference can be made in the health of population. So when we talk about technology, artificial intelligence, and things like that, there are many areas that this can be used. But when I am talking about artificial intelligence is in that knowledge creation, where you get better knowledge to the physician and the patient, so that that interaction goes well, number one, and number two, that there are better outcomes for the patient. Okay, so let's look at the big picture. The big picture is, we are looking at the healthcare system as a whole. And again, now I'm focusing on the US part of it. One of the trends that happens in developing and developed countries is that as the population gets older, the shape of the pyramid changes. Now, when you think about this image here, At the bottom are the youngest people. And at the top are the oldest, right? So as a country develops, the population becomes more cylindrical from a pyramid shape, from a triangular shape, which means that nation. Now, if you put it in this order, now how much of this, let's say in healthcare system, spends so much money that it is as big as the GDP of Germany, probably reaching closer to Japan now. So now you can imagine the magnitude of the problem. Of the GDP is spent on healthcare in the USA, which is about $4 trillion, trillion with a T. So that is a huge amount of money. When you think about, what do you get for that kind of spending? If you compare the cost of healthcare with other necessities, like housing, food, transportation, and clothing, all of these basic needs, I would say, have relatively stayed flat or even decreased. If you look at the graph here, the purple line is healthcare. And that is a scary looking graph because it keeps going up compared to other consumer price indices. Because the technology is getting better and there are more fancy treatments, more expensive treatments, whether it is operations, devices, whether it is people are living longer in when they are sick. Although you might say that overall there was a dip in the longevity of population in the U.S., but this trend is not budging. It keeps going up, so that is a problem. Now, if you look at performance of healthcare systems, if you compare different countries, U.S. doesn't perform that well. Although we are spending a lot more than other countries, U.S. performance is low compared to its spending. United States spends the most amount of money on healthcare, but it does not get good results. Now, people might think, oh, why are they spending so much money? Is it because they don't understand the science, or they don't get, they don't have the right knowledge? That's not the case. Actually, the number of studies and clinical trials keeps going up. By now it must have shot out of this graph. And so there is so much more knowledge being generated through different research and clinical trials. But why is it not, being able to improve the outcomes and decrease the cost, or at least keep the cost stable? There are a few challenges within the U.S. system where physicians are facing. The challenges being, one is reimbursement. How does a physician get paid for their services? There are a lot more regulations pertaining to a clinician's practice. And then there is this medical legal environment where physicians are being threatened by lawsuits and other negative influences on their income. So these are the biggest challenges being faced by physicians. And so physicians are under a lot of stress. Now, when I first started this talk, I said, physicians and patients are the two pieces that are very important in our healthcare system. And if physicians are being challenged with all these difficulties, then obviously the pressure is on the physicians. And so physicians are feeling the burnout, which means that they're having it is getting more difficult for physicians to practice medicine. They're under a lot of stress. There's a lot of anxiety and depression among physicians. There's a lot more outcomes of anxiety and depressions are suicide. And so it is becoming a challenge for physicians to practice medicine. And how do we solve this problem or problems? Because every single slide I showed you is becoming a challenge. Let's look at what's happening on the data side. We talk about big data, right? I would say in 2005, I think, where my previous company, Kaiser Permanente, we became paperless, which means that everything, all the business, all the clinical side, everything became digitized. So when you do that, you start collecting a lot of data, right? We call big data. Big data which means that the volume of data and the speed and the velocity and the variety of data that keeps increasing. And so it is growing so fast that it's hard to keep up with the data. So the amount of information that is available on patients, on their conditions, on their tests, and that keeps going up. And so also the hardware technology is also getting better and faster, with the introduction of cloud storage and cloud-based computing. The speed is getting faster, as we all have seen how much of information is flowing through the pipelines, through the internet. The other thing that has been happening is that the algorithms, where a computer or a machine is trying to look at different facets of information, that is also becoming faster. Now, all this is, I would say all this is great, but it hasn't actually, touched healthcare as much as we think it would. So we have this longitudinal data on patients, on how things start and what happens to them and how diseases start, what treatments are given, how they respond to those treatments. And so there is a very valuable knowledge that is packed inside of that data. Okay, so one of the things that that people talk about, again, internationally, there are different models of healthcare, but overall, you can divide them into two kinds of healthcare. One is volume-based, the other is called value-based. Now, let me explain what it means. So, where I'm trying to propose some solutions which will use data. So this is the first one. How do you bring value to healthcare? When you talk about value, it means that the benefit is comparatively more with the same amount of money you're spending, or less money and more benefit for the patient. I'm not talking about the benefit for the doctors, but I'm purely talking about patients. Which means that just because you're spending a lot of money does not mean that patient is getting value from or benefit from that spending. And that is the case in the US. we see that we are spending a lot of money, but the patient is not getting the full benefit. And each system in different countries is different, right? Let me explain what value-based care is. A value-based care means that so the business model of healthcare is based on keeping the patients healthy, right? In preventing disease, in making them better, faster, cheaper. You're spending less money, but the benefit for the patient is a lot more. On the volume-based care side, where you are treating a patient, so each time you treat a patient, you're getting paid, so you're spending more money, which means that you make money when the patient is sick. For example, if the patient has a heart attack or a stroke, you make money because the patient ends up in the hospital and the hospital bill goes up and the physician gets paid. That is volume-based care. Now, if you flip that business model, you're preventing a stroke from happening or you're preventing a heart attack from happening. So the patient stays healthier, but you make money because you are keeping the patient healthy. So you're getting paid to keep the patient healthy and out of the hospital. And so that switching of the business model has to happen. And it's some of the countries where you have government paid healthcare, that is value-based care. So they have to figure out how to keep the costs low, how to keep the patients healthy. In a private-based system, it can be mostly it is volume-based. That means if the patient comes to the clinic, the patient comes to the hospital, then you're getting paid. If the patient doesn't show up, that means you're not getting paid, so you don't make money. So the switch has to happen to value-based care. Because volume-based care, the costs keep going up because there is no incentive to control the sickness in the patient. So the cost of taking care of sick patients goes up, and so does the cost of the overall system. So that's number one. Number two, if you think about where the care is being delivered, if the care is being delivered in the hospital and the intensive care unit, that is the most expensive place to get care, right? So you want to go upstream, for example, how can you take care of the patient in the outpatient setting, in the clinics, instead of putting them in the hospital. And so you have to slowly move the care upstream. Can you take care of the patient at home or at work? Can you provide an on-site clinic? Or can you provide home-based care? Because home-based care is much cheaper than care being provided in the hospital, right? So as if you provide care at home, that means maybe the physician time and maybe the nurse's time is used up, but the family comes in and helps with providing care. So your cost of actually keeping the patient out of trouble is less. Now, you can keep going up, well, what if we take care of the problem before the problem starts? For example, when you're a young person, when you're a child, can you go and help treat, in the womb, before the risk of disease before the risk has started? Of course, we're not fully there yet, but at least we know that the habits that are formed in childhood, for example, childhood obesity is a major problem, right? If you're obese as a child, the tendency is that you'll become obese as an adult, which means that your risk of disease is much higher. Exercise, diet, what kind of diet are you starting off with a healthy diet, as a child. And so all these things that affect the society and that affect the home will affect the cost of care ultimately, right? So once you develop, poor habits, that will eventually lead to higher risk of disease in the later day. So how do you go upstream to attack the problem when it is much smaller, hopefully easier and cheaper to attack, rather than waiting until they get sick and end up in the hospital, because that becomes very expensive. The other thing I would say is that the amount of research, um, the way research is being done in the past has to change in the future. Now, let me explain what I mean by that. There are, in the olden days, physicians used to practice, and they would try different medicines and they would try different treatments. And so you would go to the most experienced physician because they had the best outcomes, because they have the experience and they have tried different treatments and they know what treatment works for what kind of patient, right? And in those days, we used to value the experience a lot more than knowledge, right? So the knowledge comes from, reading books, reading literature, reading scientific papers, um, and I have seen that in my career, how senior professors used to have a lot more value. Now, as time goes on, younger people are becoming smarter. They have a lot more knowledge because they have access to a lot more literature, and they keep up to date. And so slowly that experience part is decreasing, but where you are gaining knowledge by reading material, by looking at research and understanding, that is growing faster. Now, acquiring knowledge, like most of you are students and professors, acquiring knowledge, it takes a lot of effort on a person's being. You have to actually find the right type of literature. You have to, subscribe to journals, whether it is, scientific journals, in your specialty or, in general. So that acquisition of knowledge, there is a limiting factor, and the limiting factor is how much of science is out there, number one, how much research is happening in your field, and number two, how much of that are you able to read and assimilate and put it back into practice. And so that is a big challenge, because if there is a lot of research happening, right, it becomes slowly, it takes over all your time. And so you're not able to keep up with the literature. The other thing that happens is that when there is a study, and that study, it takes somebody to ask a question. Okay, is treatment A better or treatment B better? Let's say, for example, right? Somebody has to conceive that study. Somebody has to formulate a research protocol. Somebody has to actually recruit patients. And let's say, if it is a clinical trial, you got to have controls, you have to have intervention groups, and then, or you can compare A and B, one group gets A treatment, another group gets B treatment, and then you follow them over time, you collect data, and then at the end, you do the analysis and you get the answer, right? And that is the typical scientific method. You know, you have a question, you collect data, and then you get an answer. The only problem with this method is that it's very limited in the sense that it's the capacity of the person to ask the right questions, and it is the capacity of the researcher, excuse me. So it is the capacity of the researcher and the funding that person has to be able to recruit patients into the study and actually do the clinical trial and actually get an answer. And so you can see the challenge. Okay, so let's say you did the study and you found that treatment B is better than treatment A. But how do you spread that to the rest of the world? So you have to publish, right? You have to do a publication, and then that goes out. But how do you make physicians use that knowledge in their practice? You know, the physicians are used to treating patients with treatment A, but your research has shown that treatment B is better than A. Now it becomes challenging for you to convince the whole medical community to go with treatment B. And so that's where, you know, the professional bodies come in, you know, the Society of, Emergency Physicians, and they review the data and they come up with position statements, and they come up with guidelines, clinical practice guidelines, and they will include that piece of research into that guideline, saying that when a patient comes with this condition, you should treat with treatment B. Okay. Now the guideline is set and it is distributed and it's put in journals and everything. So everybody agrees, yes, we should treat with treatment B. But still, there is the gap between this knowledge and actual practice. You know, how does that treatment actually reach the individual physician and the patient, you know? So if you look at the whole process of generating this kind of knowledge using scientific method, the traditional scientific method, to actually patient getting the treatment, it takes about 17 years, or at least that's what the last person who studied this whole process, it takes that long for it to reach the patient. Now, imagine if it is an important piece of work where it can save patients' lives, where it can decrease morbidity and mortality, you know, it takes so long. So in these 17 years, you know, how many people must have perished or did not get the benefit of this treatment, right? And so that is a challenge. Number one, it is very cumbersome to do this kind of research. Number two, it is very expensive to do the research because, you know, somebody has to fund that research. And number three, it takes a long time, so it is very inefficient to do this kind of research. Now, how do you change that with AI? Now, I'm using the term AI very loosely. How do you use machines to do the research? Bottom line, right? How can you use the data, the large amounts of data that has been collecting to extract knowledge and then be able to use that knowledge on patients, right? That's the ultimate goal, where you generate knowledge and then you implement that knowledge in your practice so that the patient gets the benefit of that knowledge. So in this method, where you're using already acquired data, and this is huge amounts of data on patients, right? You have, number one, a lot of variety, a lot of volume, and it is more longitudinal. which means that you have years worth of data, not just a snapshot of data. Whereas in a study, in the top method, where you're taking maybe a few hundred or a few thousand patients, here you can get millions of patients. Although it's much broader and much bigger variety, but you have a lot of volume of data. And you can use the whole population. For example, we hear, when we were doing our studies here at Kaiser Permanente, we had about 4 million patients that are members in Northern California. And out of these 4 million members, how many patients are coming to the emergency department, right? Roughly a little bit over 1 million patients were coming through the emergency department. So there are 21 hospitals, so 21 emergency departments, and each emergency department it can see anywhere from 30,000 to 80,000 patients a year. And so if you put all those things together, there were a little bit over 1 million patients are coming through the emergency department. And we have data on every single patient that is coming through the emergency department. Remember, we became paperless. That means all the data is being collected in a digital format, right? So you have the whole data, and then you ask the question, you query the data, right? Is treatment A better or treatment B better? So now you have patients who have gotten treatment A, and you also have patients who have gotten treatment B. And you go back and look at how those patients behaved or what the outcomes were based on these two treatments. And you will soon realize that, oh, treatment B is better because this person, whether it is, he's off of medication or didn't die or didn't have to stay in the hospital for too long, or, some other outcome that you're looking at, whether it is mortality or morbidity. So now you have this information that is already in there. And by the way, this is retrospective data that's already in there. And all you're doing is studying that data to come up with a conclusion. And the conclusion is the answer. And so in the previous method, you're collecting a small sample. Obviously, you cannot do the scientific, the standard scientific method in millions of patients. And you're getting an answer, and it's taking a long time. How long does it take to review the data and come up with a solution? Well, it depends on how good your technology team is. I'll talk about other methodologies where you can build an engine to be able to process this large amounts of data and give you answers quickly. Instead of 17 years, maybe you can get the answer in 17 seconds. Imagine what, how big a progress that is. Of course, most physicians and most scientists will say, oh, no, you have to do a prospective study. Sure, you can do a prospective study, but if you have the backing of a retrospective study that shows that treatment B is better than treatment A, it speeds up the process, right? And so you can bring new knowledge into play much faster and in a much, I would say, more definitive way. Because a lot of the times, you look at literature, there's a study that looks at 100 patients or 200 patients, and then somebody else does the same study, but there's a different answer, right? So, which means that data that is coming, it's very small. And so it may be skewed depending on the population. depending on where you're sampling. Maybe there are sampling errors. And so there's a lot of other issues, right? Typically in the scientific method, the standard scientific method, you're taking a sample data and then extrapolating that to a larger population. But with technology, with big data and AI, you can actually take the whole population and then come up with an answer. So then there's no question about, oh, maybe it's a sampling error, you know. So that is the advantage of being able to do this. This is the system that I developed at Kaiser Permanente for the CREST network. So forget about the names of these boxes. I'll tell you what each of these are. The first one is, you know, at the bottom here, to the right-hand side, is the patient. So we need to get data from the patient. Now the data can be a simple survey, you know, a question. Hey, on a scale of 1 to 10, how bad is the pain? You know, so the patient might say 6, 7, 3, you know. So that is the kind of data that you're getting from the patient. Let's say, and then here on the right is the physician. So you need to get data from the physician. The physician is seeing the patient and you need to get data. So this could be anywhere from, is the pain on the right side or the left side? You know, I'm talking about chest pain. Okay, is the chest pain more on the right side or the left side? Or does the patient have shortness of breath? A physician will be able to look at the patient and say, yeah, the patient is short of breath, or look at the vital signs and say. And then you have the researcher. The researcher can add data saying that, oh, for chest pain patients, you can have these guidelines that are driven, that are in the literature that you can apply. So the researcher brings that knowledge from outside. And on the left-hand side, where it says Health Connect, that is the electronic health record. So this has all the data of that particular patient, you know, since the patient joined the system as a member. So you have the demographics, which is, you know, date of birth, age, sex, and stuff like that, where they live. Yeah, it has past history, which is, oh, this person has diabetes. And it has past, you know, tests results, whether it's radiology, EKG, or, you know, any kind of lab test. And so if the patient had previous hospitalizations, operations, and things like that. So you bring all this data together, and then you bring it to the middle, and then you analyze it. You know, that's what we did for every single patient, every single time they show up in the emergency department, and every time they have a specific chief complaint. For example, here we are studying chest pain, right? And when you use this kind of data analysis, you know, mainly this is large amounts of data, right? So when the patient comes in with chest pain, the main question the physician has is that, what are the chances of this being a heart attack, right? So you want to know very quickly which way to go. You know, do you keep doing testing? Do you keep them in the hospital? Or is this something silly and, you know, you can send them home? That information, you can compare this patient to 100,000 patients that came before this patient and be able to assign risk, a risk number. So in the system we developed, when the physician hits a button inside of this electronic health record, what it does is it'll analyze that data, the past patients, and looks at what are the factors that have driven the risk for those patients. And it'll come back and give you an answer. And the answer is, the chances of this person having a heart attack in the next 7 days is, because it is looking at all the patients that came before, it's looking at what happened to those patients, and analyzing that and then coming up with an answer. And the physician it's just another piece of information, but it also provides suggestions for the treatment. It might say, no need for further testing. You don't have to put them in the hospital. Send them home and they can follow up with their primary care doctor. Now, imagine if that kind of information, how much of the burden is taken away from the physician. And this is not knowledge from the textbook. This is not knowledge from the research. This is direct, real knowledge coming from the data for that population at that moment in time. And so it takes only a few seconds, right, to get that kind of information. And so that becomes very powerful in the sense that, as you keep using that knowledge, the system gets better and better because it starts to learn. It will also look at how the physician is treating the patient. And then the next time you come, it'll be different because it has improved based on this data. And so we did clinical trials. We did, 10 medical centers have the system. The other 11 medical centers did not, and we compared the outcomes. And of course, we had very positive results. So you're using data to describe what has happened in the past. You're using data to predict what is going to happen. And you're also using data to prescribe, which is send them home or add another test or admit to the hospital. And that is the power of machine learning and artificial intelligence is. I'll skip that. Okay, so how do you make physicians use the system? Because obviously, not every physician will say, I don't trust the computers, right? That's the typical thing. I remember, when I was growing up, my grandfather, he was a teacher, and this was a long time ago, right? And the calculators came out, and so I would, I got one as a present, and I would be so proud to show it off, and I would do some math problems, and I would show him, see how fast I came up with the answer, and then he would ask me questions. Okay, how about 3 times 6? And I would say 3 times 6 and the answer, and I would show him, and he actually would calculate on paper to make sure that that is correct. So physicians are very suspicious, when you show them data. Obviously, this is a new way of looking at literature, new way of looking at science, new way of looking at new knowledge. So the methodology has to be sound, and you need to involve physicians when you're doing this. Obviously, you cannot just have engineers do it because physicians have a hard time believing in it and also approving it. It should, whatever knowledge you come up with, whatever recommendations you come up with, it should decrease the effort for the physician and the time the physician spends for that particular problem. Make sure the physician's incentives are aligned. For example, if you're saying that decrease that physician's income, then they're not going to do that, right? And then it has to expedite patient care. So it should not add a lot more work, but it actually decreases the work, and the patient care should not be impeded. These are factors you need. 14 physician scientists are working in the system in that group, the CREST network I talked about. And we published over 100 papers. And I'm sure it saved millions of dollars for the system, a lot of time for physician, and a lot of time out of the hospital for patients. And we had pretty decent outcomes. I'll skip that. Okay. So, intuitively give you answers, right? The answers are there, the data is there. All you have to do is ask the right questions. So you better have enough knowledge to be able to ask the right questions. And so I encourage physicians to understand, come up with the right questions so that they get the right answers. That's my book. It's called Punish the Machine. So some people ask me, what does punish them? We've been punishing the patients. We are making them work harder. But what I'm saying is that let's flip it. Technologists, but I understand technology enough that I can see where the outcome. And there are a lot of free, a lot of people join us. So we are the largest group of physician innovators that come together and we share our knowledge, and called innovatormd.com. That's all for today. You can, if you want to connect with me, I'm on LinkedIn. That's the best way, or Innovator MD, the website. Either one of those are good to be able to go. Jacob.
Thank you so much, sir. That was indeed amazing and an eye-opener for all of us. We are all set to punish the machines, indeed. So, team in Bangalore, working day and night to punish the machines.
Exactly.
With our Triquetra technology. And before that, we have our other panelist, Dr. Arvind Singh, sir, who is, before we listen to the team Arvind Singh, sir, let us listen to your perspective and what your association with AI and what your perspective on AI is. Over to you, sir. Arvind, sir.
Outstanding presentation, which gives everybody a chance for the clinicians to get the best out of AI, and for those interested in AI to support the clinical processes and get the best value out of clinical process. That was an outstanding presentation, and it was very clearly presented. And I hope all those that are fortunate enough to attend this will gain from it. I mean, I've certainly made notes here, and I will be in touch with you to take things further. I think
Thank you.
own, exactly what you were referring to about processing large amount of data and coming to conclusions that otherwise will take us for a long time. We are working on automating the diabetic retinopathy screening. That's one of the projects I'm interested in. At the moment, the picture is taken, and the picture is then analyzed by artificial intelligence algorithms to tell you where we go from there. But Google has done that. Google DeepMinds have done that. But they are using pictures from 30, 40,000 pound cameras, non-mediatic cameras in the clinic. What we are developing is a low-cost camera, can be used in the community, and AI algorithms that will work on the images from these low-cost cameras. And our vision, if you'll pardon the pun, remains that we would like to modify this camera system to use AI-driven analysis of images for cervical screening, skin cancer screening, and oral cancer screening. There are three main problems my colleague from Bangalore tell me. And one of the persons who is involved with us is a retired professor and head of the Department of Pathology at the St. John's Medical College. And so what we are doing is exactly what you've said, using AI to get the best out of our time and diagnostic community, but do so in a very low-cost ecosystem. Because we believe that screening always works the best if you go to the screener in the community rather than expect the patients or go to the screen, or rather get the patients to come to a screener either in a clinic or in a mobile unit. So that is and I think the way you've summed up actually highlights the benefits of using AI in healthcare processes. I mean, just like we're doing it in diagnostic, I think one of the things that people forget is the processes behind our ability to diagnose and treat are the most important element in bringing down healthcare costs. Because if we don't understand the process, then we are unlikely to make savings or make the process efficient. And I think the way you have described it, you've used innovation, AI-based innovation in processes involved in healthcare delivery, which I think is fascinating. I've not found it addressed very often. That's the reason why I found it very interesting. Thank you. Thank you for an outstanding presentation.
Please mute your.
Thank you.
Please mute your mics, please. Dear friends, please mute your mics. Thank you.
I thank Uli again, for a beautiful presentation, and also the insights that Dr. Arvind had shared. And I think, one of the things that stand out, as Dr. Uli had said, is the encounter, that the first level of encounter, that is the doctor and the patient, right? And what is it that causes 51% stress in all the doctors? And that was the problem statement that we wanted to address first, right? And and when we looked out, right, one of the biggest stress factors for all doctors is that, one of the statements that they made to us was, we initially thought EHRs were supposed to help us, but we end up, after hours sitting and filling up EHRs, which is causing us a lot of stress, right? And that was one of the big pain points. And then in the process, some of them started doing it during their FaceTime with the patients, reducing the FaceTime, direct FaceTime, and the patients were complaining, doctors are typing away and not looking and talking to me eye to eye, right? And so that's where Triquetra pitched in. And we built a conversational AI-based system. We have a base platform, which is an EHR, and it is built on AI, which uses speech to text and converts the text into medical context. For example, if you have somebody who comes in.
So if you can automate that, and if you can extract the information from the conversation, that is very useful, because a lot of the time, the time spent with the patient is a lot less than the time spent with the computer, right? When you're typing all the information. And so if you can automate that process, that's definitely a big benefit for physicians. And hopefully patients will also enjoy that, because then the physician is actually spending one-on-one time with the patient rather than on the computer. Then, the patient feels a lot more comfortable.
Thank you, sir. Without much ado, I think we can take up the questions. We have a question which goes like this: which are the softwares needed for AI? I guess the participant is interested into knowing how AI works and what are the basic hardwares and softwares needed for AI. So
we'll let Joseph take that question.
Yeah. So see, the way this, today there is no set rule for a specific range of technology or a specific set of software. Okay, I'll put it that way, because I definitely will give you my recommendation, but it all depends on what system is out there in terms of the EHR system that's out there that has to interface with your AI system, and also interface with the database system that is out there, right? Now, having said that, I'll tell you that the basic AI softwares are Python and R, and Python is more widely used in terms of the libraries that are available and in terms of the ease of coding. So Python is the core, right? That forms the core. But then this core has to communicate with the front end, which could be in Angular, it could be in any other, in React, or any other form of front end that the front end that the doctor is seeing, right? And then you have a middleware which connects with the front end and the AI software. And the AI software sits on top of the database, right? Now, the database can be a MySQL server, or it could be a MongoDB, or it could be anything, right? So again, the the entire architecture that is laid out by the software team, right, is what will determine. So if you're talking only of AI, it could be R or it could be Python. And again, if you're very good with C, code languages like C, you can build your own libraries, okay? And you can, so there's no limitation. But the advantage of using codes like Python and R is that the list of libraries that are out there, that you don't have to code every simple step, but there are libraries that you can pull and use.
Thank you so much, Joseph. And can you suggest resources like magazines and websites which can help an average physician learn more about AI in healthcare?
Yeah, one of the group I suggest, where I'm an advisor also, is AI Med. They have a magazine and they have conferences and webinars and stuff. So that's a good place to learn about what is happening. It is run by a physician here in Los Angeles, but they have groups worldwide. We also wrote a book on AI, so that's another thing your students can pick up. Yeah, AI Med.
Thank you, sir. Thank you. Now we have our web architect of Believers Church Medical College and Hospital with us. He's Dr. Mormon Paul, and he would like to ask a few questions. He would like to come online and ask a few questions. Over to you, Mormon Paul, if you can unmute and switch on your video too. He would love to hear from you. Dr. Mormon Paul?
Sir, I would like to know that there are different kinds of categories that are available. So, if you are going with Python or R, for example, if you have a database of SQL, then how do you actually integrate this into the how machine learning or AI can be deployed in such a case?
Dr. Maman, your bandwidth is slow and hence we are not able to hear you properly. Is there any way you can improve your network, please?
Or if you can get closer to the mic, I think we would be able to hear you better.
Yeah.
Sure, sir. Sure. Understand this. There are different kinds of databases that are available, like SQL, MongoDB, and other things like that. So, how learning Python or R only can help integrate these two? So for example, one hospital might be running on a database of SQL, and the other might be on a different database. So how can we use Python and extract data from both these? I'm a bit naive in this regard.
I think Joseph can answer that question.
Yeah, see, every database, even if there is a huge different types of databases that are already there, say based on the infrastructure of the hospital, advantages in the architecture that you have, right? And in fact, MongoDB is for a smaller size, but as the architecture grows larger, probably you used another database which where you introduced MySQL. Okay, I think that's my understanding. But again, you can clarify that. Now, each of these databases, when you're accessing from the front end, the Python will remain the same. Okay, the access token keys. Each of these databases have access token keys. Okay, which are restrictive and which gives any software access to the database. Okay, and these tokens have a certain time frame as well that you can assign. So if your Python can access those tokens, then you get access to these databases. So you can set this up in such a way that even with multiple databases, of course, there are interface softwares that you have to, libraries that you'll have to plug in to access these, which will become the common platform, and then you can access these databases. And again, see, if when you write your Python code, when you access data, you're accessing data in a certain structured manner, right? If you're looking at the patient demographics, for example, related to a certain disease or a certain, see these chief complaints, you have the demographics, you have the chief complaints, and then that becomes your X's. And then you eventually tie it up with the Y, which is the diagnosis, right? Now, if your X's and Y's are in a different staggered manner in both the databases based on the initial architecture that was built, then you will have to do one level of pre-processing, bring it out in a common platform, and then use that data and connect the X's and the Y's, right? Hope that helps. Yeah.
Yes. Now there is a question to Arvind, sir.
Yes.
Dr. Maman, are you done? Did you have another question? Sorry, did I interrupt you? Dr. Maman?
You can as by other participants.
Okay. Again, your volume is very low and it's not very clear. You can type your questions, Dr. Maman. I can ask it to whomever you want to direct to. And here is a question to Arvind, sir. Sir, is
Yes.
there a technology for upscaling of these low quality images? Or how does it work? How does the data get processed based on low quality image?
See, we started out in a very simple way. I mean, not all of us have got as much, or none of all of us clinicians have the same command of IT as Uli has, because I found that about 15 years ago, I was invited by the CEO of a big Indian IT company called Tata Consultancy Services. The CEO of TCS wanted me to advise him on global healthcare and innovation. Now, I knew very little about technology, and I realized that the best way of coming to these, to finding solutions for these problems is a very close interaction and interface between the clinician and the IT person. What we have done with regards to diabetic retinopathy and is that myself and another colleague in the UK who is a medical retina expert, we've been looking at retinal photographs for a very, very long time. I can't tell you how long, or you'll know my age, but it's been a very long time since dinosaurs ruled the earth. And the IT people in Bangalore, they've got AI algorithms. So we sat down with them and we went through photograph after photograph of the retina, tell them what went through our minds. Because what we are trying to do when we look at a retinal photograph and want to use an AI algorithm is to describe to the clinician what goes on in my head every time I see a retinal photograph. And by repeatedly doing this, we then sent them 100 photographs on which we had put our comments and our diagnosis, dividing into the stage of retinopathy and the stage of maculopathy. And we had to explain everything. These IT people were far brighter than us. And we realized that, but the biggest problem that comes in when there is a medical technology being developed, IT, is the doctors are unable to describe accurately enough in IT person's language what we want. We always blame the IT person for getting the process wrong, getting this wrong. But what we never admit is if we describe correctly to the IT person in his language, then he can solve our problem for it. And on the other hand, this is one of the first things I had to explain to the CEO of TCS, that the IT people are structured into thinking like IT people. So if we explain to them exactly what we are looking for, they will be able to serve our needs. But we are very quick to blame because they've never practiced medicine. They've not, and yet we expect them to know our needs. and which is not the way we treat our patients. So what we felt was that we sat down with them and said, this is what we are looking for. These are the nerve fiber layers. This is the hemorrhage. And then so they did the system for us. And then we realized that they didn't understand about where each lesion is, each microaneurysm. So we had to explain to them that not only is the microaneurysm important, but where it is in relation to the macula is also important. A microaneurysm out in the periphery doesn't bother us. But so these were all the situations that we had to explain to our IT people. So I find it much easier to have a very close relationship with the IT person. Exactly what Uli is doing. What he's doing is explaining to you what the process is, how significant the process is with regards to the healthcare cost, what is the importance of the process to the clinician, and then the IT person can find the solution to all these things. But he is doing it being far more intelligent than any of us, covering both sides of it. But I find it much easier to use the brain of an IT person by explaining the process to him and then letting him tell me a better way of doing. I mean, we've been practicing medicine for 5,000 years, since the time of Charak and Shushruta. Our processes haven't changed very much. But an IT person, in terms of IT knowledge, if he understands the process and we explain it to him, then he can find us a solution. Now, specifically with regards to the imaging software, what I found was I told these IT people that these are the lesions we want to pick up. They then worked on algorithms to clarify. In fact, they said in some cases, they got more information by reducing the resolution of the images. And I also told them that in clinic, we have red-free photographs that we take, which show up certain pigment epithelial changes much better. So they then took the images, reduced the red component from it, and then analyzed it. So I think as far as the intricacies of image analysis is concerned, those IT people know much more than me. I just tell them my requirements and they get on with it. But I can find out for you, since you're in, you're close by, and these guys in Bangalore, I think I'm quite happy if you get in touch with me. I will be able to put you through to them and they will give you the technical questions of the IT side of it. I can explain to you everything about pigment epithelium and diabetic retinopathy and microangiopathy and the bleeding of blood vessels, but I don't know much about the image analysis that these boys are doing.
Thank you, Arvind, sir.
Okay.
It's always a pleasure listening to you. And yes, Dr. Maman. Dr. Maman is one of our shining stars. He is actually changing the landscape of all that is IT in our institution. So he's our champion. Dr. Maman, you said something?
Sir,
Yeah.
Sir, I'm so much interested into this. That's the reason why I'm keeping on asking questions.
You should.
I've been recently. So
Dr. Maman, we are losing your connection again.
Admitted into a program called LEAD.
Yeah.
So we have. I was actually admitted into a program called LEAD by TAPME, which is related to business analytics and decision sciences, in which so likewise I was researching on the topic so much that I was confused. The big data is different from the normal R and Python the language that we use. So there is programs called Hadoop, which is related to big data and big data analysis. And on the other side, there is R and Python that is on a much lower scale. So which one should we look forward to, or which one should I or personally anyone aspiring to becoming more into this kind of topic should focus on? Which one will be better?
Yes, I think Joseph would be the right person to handle this.
Yeah, see, Hadoop is another platform, right? It gives you access to it. But as your data goes big data, right? Even from plotting analytics and graphs, right? You can't use the basic Python libraries. You'll have to use something called Tableau, okay, which can access larger set of data. So it again depends on, so there's no number as such, right? When you talk of terabytes of data is there, but what is the level of data that you are accessing? That's the question that you have, right, to answer, right? So if the access points are terabytes, then it becomes big data. Just because it's statically there and you're not using it, then that's just data, right? So yes, like you said, if you want to use a larger, if the data is huge in millions, for example, if you want to plot graphs of millions of data points, right? With Python libraries, it will just sit there and it will give you after 30 minutes or so, right? But then you venture in and use libraries like softwares like Tableau, which do parallel processing of the data and brings all the data together into the graph and plot it to you in a few seconds, right? Microseconds. So these are applications like Azure data, but a good starting point would be basic Python and its libraries.
Okay, it's very clear.
Because you see, each time you use fancy softwares, right, you end up paying cost also, right? Cost is also a thing where you have to buy licenses, and and really not at a stage to actually extract the maximum benefit of it, right? So
Maman, I hope that answers your question.
I think Dr. Uli had
Yes, sir.
was saying something. I think he was in mute.
Yes, Dr. Uli.
So, I mean, looks like Dr. Mammon wants to understand the landscape of the whole architecture and also understanding the decision science. So, I would say, yeah, if you join a course, if you want a refresher, then you can buy a book and read about it. But if you want to join a course, you have to look at data science courses that may be available at a university near you, or even online. There are a lot of data science courses. I think that's what you need to start with, and then go from there.
Yeah, that's very vital advice to you, Dr. Maman. And thank you, sir. So thank you, Dr. Oli, for all those resources you have put up in the chat. I think it will be really beneficial for our viewers. And yeah, I think all the questions are answered. And
I have a question.
yes, ma'am. This is Dr. Alice David. She's our research head at Believers Church Medical College Hospital. Welcome, ma'am, please.
My question is
You can switch on your video too, ma'am, if you don't mind.
My question is to Dr. Uli. And so from your talk, what I understood is that you're mostly doing statistical analysis. So if statistical, and how is that? Is it the same? Is statistical analysis and AI the same? I never thought it was the same. So can you clarify?
Sure. It's just a matter of scale. So when you're dealing with AI and big data, you are getting the data from the whole population, right? Yeah. When you're doing statistics in a typical research study, you're taking a sample of a population and you're extrapolating those findings to the rest of the population. So if you have the whole population and you're studying the whole population, that is the truth. That's the ground truth. Let's say if a pharmaceutical company says, hey, my drug X works great and you should stop using ABC drugs. But in reality, when you actually study the population and you're looking at drug A, B, C, and drug X, and you're comparing, the evidence is obvious. What you see is what you get. What you're looking at in the data, what you're looking at in the outcomes. And so there's always this ambiguity when you have a small research study that says that this treatment is great for this disease, but when you actually compare that in the real world, it's also called real world data or real world evidence, then you don't need a lot of statistics to show that, oh, okay, it's quite obvious that this drug is better than the others, or vice versa. We have done some studies in looking at, there are newer drugs that are coming out, for example, for heart failure and for diabetes and kidney disease. So these drugs are expensive, right? And so you have these older drugs, which are cheaper relatively, compared to the newer drugs, which are very expensive. Now, what the manufacturer will say is that, this is an expensive drug, but it is much more effective than the older drugs, right? So how do you know? They did a study, and it did show that it is more effective in their limited population. But when you actually put it to test in a real population, then you'll have a much better understanding. So what we found was that, yes, the new drug was more effective, but it was more effective in a certain specific type of patient, not in all types of patients. And so you have to figure out, okay, how do you identify, and that's where precision medicine comes in. How do you identify the patients where this specific drug is useful, whereas in other patients, it's not useful? We developed an application for diabetes. Now, if you think about diabetes drugs, maybe there are 60, 65 different drugs. How do you know which drug will work in which type of patient, right? How do you match those? And so we studied looking at characteristics of different patients and which type of patient this specific drug will work in. You do need to understand statistics. Statistics is the basis for even for big data, but you need to understand that. There's no way around it. But there are different types of statistics that you'll be using when you're using big data and artificial intelligence.
Really, can I amplify that and answer the question also?
Yes.
The biggest advantage of AI, even when you're looking at the limited scope in statistics, is an AI system can analyze far more variables in a much shorter time. For example, if you ask me, out of these 100 people in this village, how many people died in the last 6 months? I can give you a number. I can simply add up the number of people, add up the number of people died. But if you ask me a question, how many people died that had diabetes, unmarried parents, were 5 feet 6 inches tall, and had no children? Now, for that, I will use AI, because the AI systems, there are two major advantages of AI system. One is that they can analyze a large number of variables on a very large quantity of data. But more important, you can build AI systems so that they learn from the way they're analyzing it. So if I asked you this, and I did up an algorithm for you, which gave you the number of people who died, who had married parents, were Hindus by religion, were 5 feet 5 inches tall, had diabetes, and had diabetes for 15 years. And then you asked me a question about, okay, you told me how many men died. Now, how many women died with the same criteria, except that we are looking at women who are not 5 feet 5 inches, but only 5 feet tall. I can use the same algorithm, but teach the algorithm that the only difference the algorithm has to make is the height of the people and the sex. So the biggest advantage of an AI algorithm is every time you use it, you can program it so that it learns from its experience. And that is the biggest advantage. So it does the statistics, same statistics that you and I can do with a pen and paper or even a calculator. But an AI algorithm can analyze large amount of data much faster and see more variables and can learn from its experience. That's the biggest advantage of AI.
Well said.
Thank you. Thank you.
Thank you, sirs, both of you.
Both of you.
Yeah.
I just want to clarify. I have used statistical.
Ma'am, can we, for the same question, can we also take Joseph's perspective? He would like to say something, I guess.
Yes, yeah, please.
See, one of the beauty of statistics is that we've used it for a long time, and one of the fundamental assumptions, right, in statistics is that your data is normal, that you have a bell curve, right? That's a normal distribution, and then you assume that within plus or minus 1 sigma, 2 sigma, the data is fairly normal. But unfortunately, the human, when you go into the medical science, like, Uli was talking about the various demographics of patients and the diabetics and the 60 medicines that are out there, there's a huge variation, right? So the fundamental assumption that the data is normal is not valid here, which means statistics will fail miserably. And that's where you shouldn't go the statistical route with so much of variation in the system where the distribution of data is not normal. Right? And in statistics, we have various methods where a data is not normal to work on it, modify the data, right, and make it normal, right? Like the R-square methods and other methods that are out there that actually make non-normal data normalized. You normalize it, and then you look at the data. Only after normalization, statistical methods become valid. But the beauty of AI is that it can study various variations and understand the pattern, and based on the pattern that is recognized, it will apply it back to the data, right? So basically, I'm talking about the variation, the x's that you have connected to the y, which could be again not single y but multiple y's, right? And then you study the pattern, and it is multi-layered patterns that you can set up in using the AI models, and each of these patterns can then get connected to those multiple y's and give you a differential diagnosis or a differential outcome, which, unlike the statistical methods, assume it to be, and it gives you a fixed outcome, right? Fixed output, right?
Oh, yes, thank you. That makes sense.
Yeah.
Thanks a lot. And because I have, I'm basically a statistician, and I have used statistics on large data sets, like 4 million data sets also. And I have used this software called SAS. So that's why I wanted to know how it is different. And thank you, Mr. Joseph. I think you clarified my question to the point.
Joseph, what you just explained looks to me like a hyper-synchronized, hyper-variant meta-analysis.
No, but that's the fundamental difference, right? As AI engineers, that's where we learn, because traditionally people who have used statistics and have seen where it has worked in the field will actually challenge you.
Yes.
That's where variations come into picture that brings the beauty of it all, that AI can take in these variations, right? Because otherwise they'll just hammer you down saying with one statement, linear regression works fine, right? And then they will prove it to you, right? And with a small data set, like Dr. Uli said, right, on a small data set, linear fit will work. But on a larger data set, which is multi-dimensional, right? It will fail, and which that data, even, and it's easy to, and also from a perspective of understanding the complexity from a linear regression, it's very easy because it's 2-dimensional and our mind can perceive. But when it gets multi-dimensional, where the human cannot perceive it, right? Multiple combinations, the average mind will not be able to perceive it. So they will not be able to appreciate the beauty of AI. And that's where experienced people like, Mr. Arvind saying, where he talked about, even with the course data, AI is able to see it, right? Which the normal naked eye cannot see it, is actually appreciated, right? And so that's where, as you get into the field, you appreciate more and more of what AI can bring to the table.
See, I must say at this point, pay tribute to my teacher. In CMC Vellore, biostatistics is a very important subject, particularly for the first 2 years of study. And the legend of biostatistics, Professor P.S.S. Sundar Rao was the head of the department when I was studying.
Oh.
And he has not only taught me biostatistics, but he has also taught me to love biostatistics. And I was speaking at a symposium in Pondicherry at Mahatma Gandhi Medical College, and I had invited P.S.S. Sundar Rao to come and speak. And the person who was chairing it, the professor of surgery and the dean, first stood up and said, oh, I've always admired Professor Sundar Rao. I've never met him, and I've been reading his books all through. And then Sundar Rao reached out into his bag and said, here is the latest edition for you. Because I find that, I don't know if you've heard of him, but
yeah, he was my professor too.
Is your professor too? Well, there you
Yeah.
go then. I mean, he is a legend. Most people don't like dry subjects like mathematics, and it's almost as bad as pathology. But Professor Sundar Rao can make you love statistics. I still remember. And only thing that I have changed from his teaching is my examples are much more sarcastic and much ruder than Professor Sundar Rao's were. But I find that for anybody studying any clinical science, fundamental, the core of at the heart of it is statistics. And exactly what Uli was saying, and subsequently John has been saying, I think Joseph has been saying, statistics, understanding of statistics is at the core of it. And what both the speakers have shown us as something that we can appreciate is their clear understanding of statistics and their ability to explain it to us. I think that is the skill that all of us would love to aspire to possess, which these two speakers have shown us today.
Thank you, sir. I think both of them are statistically significant in statistics. And is that surgery professor you're talking about is Dr. Ananthakrishnan, sir?
Yes, Ananthakrishnan was, yes, he stood up and said, I've always admired Professor Sundar Rao, but I've got his older books, the editions of which I've read. So Sundar Rao brought out the new edition. And because I was asked to organize a symposium on behalf of BMJ, the British Medical Journal, and I was on the board of BMJ at that time. So the speaker, one of the big advantages, as Uli will tell you, when you're organizing a meeting, the biggest advantage, you can choose to invite whoever you want. And you generally invite the people that you want to hear. And I got Sundar Rao for that reason, and he traveled to Pondicherry to give the talk. But I think the biggest advantage of this thing, organizing a meeting, is that basically you call everybody that you personally would like to hear.
True, sir. Yes. And Dr. Ananthakrishnan is a legend in general
Yes.
surgery, and he's from JIPMA. So
yes, he's from JIPMA. Absolutely right.
And like teacher, like student. So we have another legend in Alice ma'am too, who is creating ripples in the research field in our institution and beyond. So thank you, ma'am, for your valuable inputs, and thanks to our amazing panelists, Arvind sir, Joseph and Uli sir, for your amazing inputs to this effect. So yeah, so any more questions? We have really enjoyed our session so far. I think it's almost reaching to us. So so it's been really amazing. I mean, I just saw the time and realized that we have gone a little too far, and it's really great. So
time flies when you're having fun.
I know, I agree.
Absolutely. Here, there's one more.
Listening to interesting speakers. Yeah.
Yes, sir. True, sir. Very true, sir. We have one more comment where one of our doctors have mentioned that it was really an amazing presentation, an amazing session, talk, and discussions. So, so it's there in front of us. It's been truly an amazing session. My special thanks to Oli sir, who has resolved to come and speak to us at 4 a.m. Can you believe it? And I was really guilty when I converted the time, and he had no qualms about it whatsoever. He said, "I'll be there, Jacob." And sir, hats off to your commitment, hats off to your enthusiasm. Thank you so much for taking your time off, sir. And
Thank you.
Thank you.
round of applause to you and our panelists. Arvind Singh, sir, you are a great encouragement, and you're a great inspiration for all of us. And looking forward to more discussions with you too. And you've also taken your time off, precious time off, to spend with us and bounce off amazing deliberations. Thank you so much, sir.
Thank you. Thank you very much.
Thank you.
And Joseph McNaim, it's so weird to call him Joseph McNaim. I am always used to calling him Anna, which translates to brother. So he's my first cousin, and we've always looked up to him as an elder brother, a great role model for our family. And of course, leading Triquetra from the front. I'm very sure that he's going to break all barriers and very soon reach Silicon Valley too, as one of the top AI companies in healthcare, with, of course, a lot of help and inputs from stalwarts like Oli sir and Arvind Singh sir. Thank you so much, Joseph McNaim.
Thank you for giving me this opportunity to share, the panel with Dr. Uli and Arvind Singh. So definitely will set up try to have a chai with Dr. Arvind, since he's also in Bangalore. And probably
thank you. I think, Jacob, what you should do is put together email addresses of people who have been on the panel, the speaker, and those that have asked questions. The advantage would be that then we can continue with the interaction for a lot longer.
Absolutely, sir. Absolutely.
And it'll be wonderful.
We can even form a WhatsApp group.
Yeah, because the people who I've heard today, the speaker, the panelists, and those that have asked questions, I would love to continue the interaction. I've learned a great deal today, and I would like to continue with my learning.
Amazing, sir. Absolutely. Taken, sir. We will definitely do that.
Yeah, I just want to tell Dr. Arvind that we too have started taking images of our ophthalmologic, our Department of Ophthalmology and the Department of Pathology. We have started taking images. So nobody's asking questions.
No, I think what I'll do is I'll put you in touch with the Bangalore team. So instead of reaching out to us here, myself and my colleague William here in Glasgow for the images, they can interface with you directly, because at the end of the day, we are all in it together. Yeah. And as Uli will tell us, the more data that comes our way, the better our conclusions will be. So I think we will, it'll be nice to interact with each other and apply whatever we are trying to develop to the images that you're gathering. Absolutely. It'll be wonderful.
Yeah, that could be really an amazing collaboration, isn't it, sir?
Yeah.
So Alice, ma'am, probably you can note it and follow that up. Yeah.
Sure.
All right. So, so on that note, or rather a very high one, I think we should come to an end. All good things come to an end. So, so there we are.
Thank you very much. Thank you very much.
Thank you, Jacob.
Thank you
very much indeed.
Thank you. Thank you. Thanks, everybody. And yeah, have a very safe evening and day. I mean, we have different parts of the world being linked together. So yeah, take care. And signing off from Believers Church Medical College and Hospital, Dr. Jacob. Thank you.
Thank you.
Bye.
Thank you very much.
Bye-bye.
Bye.